Yes, ma'am. And thank you all for your patience and for being.
Lynette, you just lost audio. Goodness. Okay. Sorry, everyone. This is Evelyn. We'll get started soon. I think we're just having some problems with our WebEx. I think she's back.
Can everyone hear me?
Yep, we can hear you now.
Okay. Okay, excellent. I think we've solved the problem here. You will see 2 EMI Advisors hosts, but I think everything is as it should be. So thank you all for your patience and for bearing with us during this little bobble. This is Lynette Elliott. It's April 16th, and you have joined us for the Gravity Project Housing Data Concept Review. Next slide, please. If you would like to post
Oh, Lynette, we lost you.
Okay, can you hear me now?
Yeah.
All right, thank you. And can the other folks please mute their lines? Okay. Let's try this again. If you would like to pose questions or comments during the call, if you're new to these calls, we use the chat feature so that everyone can share thoughts and comments and questions throughout the presentation, even if we don't have an open question answer session. And please send your chats to everyone so that we can all see them. We've had some really wonderful chats in the last few weeks when everyone contributes and shares their thoughts. Next slide, please. And can everyone please make sure they are on mute? I'm hearing some background noises. And Evelyn, if you would like to comment on this slide, this is new to us.
Sure. So welcome, everyone. We are now moving forward and include an antitrust practice slide in our presentations. This is actually common practice, very much used right now in other FHIR accelerators that bring multi-stakeholder groups together. So we just want to remind everyone that we do intend to comply fully with federal and state antitrust laws. So we're asking all, particularly those that provide services or products, to refrain from discussing your product during the call and any of that that have a market effect. So as noted here, participants should not discuss their pricing or other pricing or any term like that. And please adhere to these guidelines, not only avoidance of antitrust violations, but avoidance of behavior that might be so construed. So nothing, it's just something to keep us all on the same page, and we'll present it during every meeting. All right. Lynette, I can just keep on talking. So I know in the interest of time, I have a lot to cover.
Okay,
so
yes.
just,
thank you.
So this, again, a common slide, if you haven't joined the project, please do so. We ask you all to do that because that's how we track and we send out communications and calendar invites. So if you're joining us for the first time, welcome. We're delighted to have you join us and hear what we're working on. And we strongly encourage you to join the project either as a committed member or other interested party, and therefore you can receive communications from us. We also want to acknowledge all our founders and funders in kind support to date, so they're listed here. We cannot do this without them, so we are appreciative, and all our sponsors have their own Confluence page. We do acknowledge our sponsors as well because we are actively fundraising for the Gravity Project. We are a small project, and we have a lot of work to do. So if you are interested in sponsoring and therefore would like your name and organization acknowledged, please reach out to us. So we have our email here, and we have a sponsor web presence. All right, here is our agenda. Again, in the interest of time, I know we've got lots of stuff to go through, so we'll go quickly through our roadmap and upcoming schedule, and then I and Sarah will give announcements. Linda will talk through where we are with housing domain submissions to date. Thank you again in advance for that. Sarah will review updated intervention definitions and then hand it over to Rich, one of our housing subject matter experts, to discuss an overcrowding concept. We'll hand back to Lisa Nelson, our technical director, give us a quick update on where we are with the FHIR IG and the Connectathon, and then Sarah will remind everyone what their homework is. Here's our timeline. For those not familiar who haven't seen it, we're working towards our proposed schedule. And every week is more or less the same, going through the data element submissions, where we're at, giving you all an update, and as well where we are with our FHIR implementation guide development. As a reminder, our deadline for submitting housing instability data element submissions is May 1st. We did push this back out from our original date. If you do need more time, please let us know. We really appreciate all the data elements submitted to date. And if you do need more time, we appreciate that this is a challenging time, and many of you have not had the time, of course, with more pressing issues around addressing the pandemic efforts. Please let us know. We are flexible. And we want to acknowledge, so if you do, again, maybe this is just a plug for you all, if you do intend to submit, but May 1st is a hard deadline for you, please let us know. Here's our timeline. Just quickly acknowledge that the Gravity Project consists of two main streams of work: domains and FHIR IG. So all our meetings, we talk about where we are within the domains. We're in housing, we're in the middle of working on the data set identification, and the FHIR IG stream is in the middle of developing the FHIR IG. So that's why you'll get an update on both during these public calls. All right, so just quickly from an announcement, for those that have not been keeping track with grants publications, we want to acknowledge that ONC has released a new grant opportunity called the Leading Edge Acceleration Projects in Health IT Special Emphasis Notice. This grant has an area that would be an interest to the Gravity Project stakeholders. Area 3 is about integrating healthcare and human services data to support improved outcomes. So this is an opportunity to really think through on how you can integrate both human and social services data. And so please do spend some time reviewing it. There was an informational session yesterday. A recording will soon be made available. And if you have an interest, you have to submit it by June 8th. Also want to acknowledge our upcoming Connectathon. Lisa's going to spend more time going through this, but there was a meeting yesterday. Now I'm looking at, and I didn't realize I updated. There was a meeting yesterday. The minutes are available here. We also want to announce that we are working as part of the Gravity Project on a parallel track called the Care Coordination Track. So we will be building off the Gravity Use Case 1, but this Care Coordination Track really is around demonstrating the use of FHIR to support the exchange of data across the continuum. So it incorporates, primary care, acute care, hospital, skilled nursing facility, home health, home and community-based services, and of course the ability of the patient person to also access their information, either available through an assessment or a care plan or person-centered service plan. So it is aligned. It's something that we are coordinating. We have two Connectathons. So again, the May is a virtual one. Lisa will spend more time, and she'll talk about the MyHIN one too, both virtual for now. Hand it over to Sarah.
Hi, everybody. Sarah's here. Can you hear me?
Yes.
It's great. Okay, so I just wanted to briefly plug. So we decided perhaps the best way forward to kind of consolidate the collaborations out of Gravity was to stand up a Gravity-specific space on our Confluence site. You can see if you go there, and here's the link, that we've assembled a lot of the thoughts that came out of the chats and in email communications. Up until this point, we're really hoping to jumpstart some of the collaborations that we've seen happen in chats and have a place for them. You do need to develop an HL7 login to comment on the blog, but everything as it stands right now is free and accessible to all. So some of the unique Gravity projects that are going on right now, especially some of them coming out of the HMIS HIT work group, will be there shortly. And we really look forward to trying to foster some of the transprofessional collaboration that Gravity does so well. Next slide, please. And then off to Linda. Linda.
Oh, thanks, Sarah. Next slide, please. So this is our standing slide that we have in every session showing how we're progressing with the submissions of data elements. So as of, well, actually, as of yesterday when we finalized this slide, we had 6 submissions received. I actually got one this morning, so this will be updated for next time. So you can see how many of the submissions contain screening tools and questions, diagnoses, goals, and interventions. 5 of the 6 have been reviewed, and again, you can see their dispositions. So we're starting to now see that several submissions are using some of the same screening tools. Oh, go back one slide, thanks. Some of the same screening tools as others. You'll notice we have some PARC in there, and those are ones that are appropriate for a different domain. They have some for transportation, and we actually have a couple for the next housing phase, which is the inadequate housing domain. We'll talk about that in just a second too. And the ones on hold, these are the ones where we need a little more information from the submitter. So emails have gone back to the submitters asking for either a full copy of the screening tool so we have a better sense of the flow and the questions, responses, and that, or just a little bit more information and definitions for some of the submissions. So next slide, please. And as we have done in the past, we are starting to put together the logos of all of these submitters. As you can see, there's plenty of room here, so we can add more logos. And as Lynette said, if you're planning on doing a submission, you need a little more time before May 1st, please let us know. We would like to get as many submissions as we can just to see the depth of what everybody is using or collecting for data elements for screening, diagnoses, goals, etc. Next slide, please. This is just a reminder that we actually have 2 phases. I believe Sarah spoke to this last time. Focus now is housing instability and homelessness. Phase 2 is inadequate housing. If you do send us data elements for inadequate housing, we're just going to hang on to them, and we will start working on those when we go into that phase. The 2 areas that are in red are reminders that the 2 areas, and you can see from the statistics slide, where we really don't have a lot of submissions, and those are in the goals of care in the interventions, focusing on program names, definitions, provider practitioner roles, and what would be applicable intervention activities or services in this housing instability and homelessness domain. So please, if you actually have some of those data elements specifically in those areas, please don't hesitate to send us something. And I believe, next slide, this is just a reminder. After this meeting, tomorrow or in the next couple of days, we will be publishing the latest master list. This is the link for where you can go see it. You can see what's been updated to the master from the one we published after the last meeting 2 weeks ago. Next slide, please. And this one is a reminder on how to submit. So if you go to this link here, you can submit either via the spreadsheet, which you can download, or our web tool. Again, we're really looking for submissions by May 1st, but we can be a little flexible if that's going to be hard for you given the current circumstances. And I believe now I will turn this over to Sarah for the next section.
Hi, yeah, so this is an update on some of the intervention framework concepts we established in our food insecurity build. Based on hitting the rubber in the road a little bit regarding current SNOMED definitions compared to our definitions. So even though our intervention framework went through end-to-end review, there really were some concerns when we started to think about building these interventions into SNOMED. So we wanted to come back and represent and show to the community some of the work we've done on the framework over the last chunk of time so everyone could review. So you can see the tables organized with the first column in blue is the intervention type as we've designated it. And for those of us who were in the food insecurity build, you know that these intervention types then wrap around provider roles and programs in order to create the full breadth of concepts we need to address a given domain. So there's referral, evaluation, which is equivalent to assessment. We established an evaluation of eligibility term or intervention to wrap around concepts that require eligibility assessment. We have assistance or assisting, counseling, education, provision, and then the coordination. So you can see many of these concepts had to be refined in order to reflect existing SNOMED definitions and SNOMED approaches. So there's the next column, former gravity definition is the definition as it stood, as it went through end-to-end and consensus review. And then current proposal is the work that we're bringing back to the community for your thought. And I'm presenting this now. We will get some questions now, but really consider this one of those things that we want the community to digest and really take in, and then maybe we can revisit next meeting when we come back. So the proposal for referral is an act of clinicians sending or directing a patient to healthcare professionals and or programs for services. Evaluation and assessment are equivalent in SNOMED, so we had to collapse a little bit of our approach here. So the definition of evaluation and assessment is determination of a value, conclusion, or inference by evaluating evidence, and this is directly from SNOMED. Evaluation of eligibility for is just built on what you can see the definition for evaluation or assessment. Assistance gets stripped down to very simple, give support or aid. There was a problem in our definition because we specified that it was non-clinical aid because we definitely do use the assessment assistance in our intervention framework for non-clinical activities, but of course in the broader SNOMED world, assistance is used for clinical activities too, so we had to step back a bit and align it with that definition, and we can operationalize it in non-clinical settings, but for the purposes of the definition of the intervention, we had to go broad. Counseling is as it stands because it was already based on the SNOMED definition. Education, this is one where we are staking a little bit of a flag in the sand because we're proposing a definition that strips out two different concepts from the education definition within SNOMED. You can see the education definition within SNOMED, which is what our previous definition was, is a procedure that's synonymous with those activities such as teaching, demonstration, instruction, explanation, and advice that aims to increase knowledge and skills, change behaviors, and assist coping. There are enough pedagogy folks in our group. There was a little bit of pushback in including the change behaviors and assist coping because in much of education literature, increasing knowledge is the aim, but changing behaviors and assisting coping is the realm of counsel. So for now, we're proposing that we just strip those two concepts out and leave it as it stands right here without those two. Provision is the clear SNOMED definition, which is to supply, make available for use. And then coordination is a novel concept. And if you remember from the food insecurity work, for us that came from the AHRQ definition of care coordination, a coordination of care. So this becomes, based on the AHRQ definition, a process of organizing activities and sharing information to improve effectiveness. So we do have a lot to cover today, so I'm hoping to move along unless there's any pressing questions. If you have any distinct questions about this piece, Matt Bishop, maybe Matt, can you and I take that via email so I can better understand? And then we can have time because it's already 4:21. Thanks, Matt. Matt and I communicate by email well. So anybody else wants to email me questions regarding this, we can do so. I definitely do not want to cut too far into the content of the overcrowding and doubling up conversation. Any other questions? Sounds good. Okay. So moving on. Next slide, please. I'm going to pass the torch now to Rich, and The timeliness of this conversation regarding overcrowding concepts really is in direct relation to the COVID-19 crisis and understanding how concepts of overcrowding have direct influence on transmissibility and acquiring a COVID infection of the individual. We're seeing that play out in strategies in the homeless sector across the nation right now. So passing the torch to Rich Sherwood.
Great, thanks. You can go to the next slide. So I'd like to just talk very briefly about overcrowding as a housing concept and something that I'm certain members of the community may wish to submit on. So there is a history of research around crowding and its impacts on health. There's research that shows that it is negatively associated with mental health status, stress, child-parent interactions, and relationships, as well as sleep. It also is associated with increased risks of childhood injuries for both child and adult, elevated blood pressure, respiratory conditions, and exposures to infectious diseases, as we can all imagine in today's world. Next slide, please. And in addition to negative health outcomes for the individual and the household, it also has ripple effects, especially around access to health care. And these findings were cited in the Children's Health Watch Housing Instability paper that was published in the American Journal of Public Health in 2011. And most of the research that we relied on at that time was actually dated from the 1990s and early 2000s. And so I'm certain that there's more recent research out there that perhaps some of you are, have been involved in or aware of. Next slide, please. So what exactly do we mean when we say crowding or overcrowding? So HUD has done a comprehensive review of the evidence and found that there are a few accepted definitions, and the one that's most prevalent is the definition that Children's Health Watch used in the paper that I just referred to, which is defining crowding as having more than 2 people per bedroom or is temporarily living together because of economic difficulties, also known as doubled up. And there is a link here to that HUD study that looks at the various definitions of crowding, the one of number of people per bedroom. They also look at square footage as well, but that's the most widely used definition. Next slide, please. And so Children's Health Watch, we looked at crowding in our initial study, looking at both multiple moves and crowding as indicators of housing insecurity. And what we found in a sample of low-income households with young children was that crowding was significantly associated with both household food insecurity as well as child food insecurity. But what's interesting in the context of this one study was that crowding was not significantly associated with negative health outcomes, such as self-report of FHIR poor health for caregivers, as well as FHIR poor health report of the caregivers on behalf of the child, as well as developmental concerns, maternal depression. Next slide, please. Oh, sorry, I think we just need to go one slide forward. And so what we're looking at here, this is a table from that report, that paper rather, showing the crowding, the families that experience crowding and families that experience multiple moves in comparison to those who had secure housing. And I've highlighted in the red box to the left the families that experience crowding, and you can see the significant findings related to household and child food insecurity, as well as the findings related to developmental risk and FHIR poor health. We did find both food insecurity at the household and child level, as well as child FHIR poor health and developmental risk to be significant for multiple moves. I do want to mention that there are some limitations and considerations from this study. Number one, it was just a single study. Number two, Children's Health Watch has a unique sample. These are caregivers with young children under the age of 4. This is in 5 urban safety net hospitals. So I think other studies looking at the general population or rural populations, older adults, that sort of thing would be certainly warranted. I also think a potential explanation for the lack of findings for crowding and poor health outcomes might be related to the fact that you have a young child that is in a situation with multiple adults, and that could potentially have even a protective health factor in there because there's added supervision and adult presence. But these are just guesses. Okay, next slide. Great, and we are happy to answer any questions. Hopefully this shed a little bit of light on the concept and piqued interest in possibly submitting elements related to it.
Rich, thank you so much. So one of the benefits of having Children's Health Watch be involved is they are such a source of literature themselves. So Lucy Johns had a question about the role of overcrowding with domestic violence, and there is literature on that. Surely it was not contained in these slides because Children's Health Watch represents the literature, represented some of the literature, but certainly didn't represent all of the literature regarding overcrowding. But it is definitely something where we know of in the lit that's out there. Any other questions before we move on? I gotta leave one final plug here when it comes to these concepts and again COVID-19. This is a missing area in our current submissions. We have the CMS accountable health communities, inadequate housing questions. We have prepare and the VA and CMS questions on homelessness and housing instability. These concepts are a big area of need. So especially when we consider trying to wrap around the current pandemic. So if there are researchers that that are out there using overcrowding questions, please let me know and let us know and submit them. I am going to make a submission myself based on lit review that I'm working on with Siren, just to try to get these concepts in the master. And we thank you so much, Rich, and I think we're ready to move on unless there's other questions. I think we're good. Thank you, Rich. Okay.
Thank you.
Next slide. On to Lisa.
Thank you very much, Sarah, and thank you, Rich. Next slide, please. We're going to have an update today about our progress on the development of the FHIR IG. We are in the
Oh no, Lisa, we've lost your connection. Oh, we're having technical difficulties. Lisa, can you hear us?
Oh, I made it just in the nick of time. Yes, when my phone says it's out of charge, I have to run immediately to get another handset. Okay, thank you very much. So we are in the tail end of our work on version 0.0.3, heading towards 0.0.4, and that means that out of this incremental progression, things are definitely getting more solidified, and our ability to produce FHIR IGs without errors in them is getting better. The content is getting more complete, and we just keep slugging away at it. So the important thing to know is that we now are starting to have some opportunities to do some testing of the information that's documented in those in the implementation guide. Next slide, please. I'll summarize these red spots that you see in the Connectathon testing area. we have 2 virtual Connectathons coming up. We're getting ready right now for the HL7 Connectathon that's going to be happening for 3 days between May 13th and May 15th. This will be a virtual Connectathon marathon, I think. It's going to be interesting, our first one that we'll have done in a virtual way. But it'll be followed right behind it 2 weeks later with another, a little bit shorter, slightly different kind of experience, virtual also, but working in conjunction with the MyHIN folks in Detroit, hosting another opportunity to test some of this guidance that we have been documenting in our FHIR IG. And then hopefully in September, we'll be together in person for a Connectathon in Maryland. We'll see. If not, we'll be much better at doing virtual ones by then. The link that you see on the bottom of this slide is the main landing page for all things related to Connectathons associated with testing the Gravity FHIR IG. So that's a good general spot for staying connected with all of our testing. Next slide. The May Connectathon the registration just opened the other day, so I know a lot of you have been asking about this and wondering about it. We do know that the Connectathon is going to cost $100 for all 3 days. If you register, you get a virtual seat at the table there for 3 days for $100. If you're not an HL7 member, it is, I think, oh boy, now I'm having trouble. $150. It's some incremental. It might be $199. It's an incremental amount more than that. If you can reverse back one slide, please. I'm just not quite ready to depart from that page yet. Great, thank you. So the track itself that has been defined for our work with gravity, there's something that's called a track plan. That is accessible off from our Connectathon site, and the track plan describes the different roles that are available, the main scenario that we'll be exercising, which is use case 1, 3 different scenes that make up use case 1, and then individual steps for each of those scenes. It breaks it down into nice digestible bite-sized pieces, and it gives us an opportunity for people to understand the steps, get engaged at that level, and I think if you visit that track page, you'll get a little bit better feel for what the activities will be, the testing activities will be during Connectathon. We have been holding prep sessions. So if you have interest in Connectathon and you have not been attending these, I think we've done 5 of them so far. They've all been recorded, so it's okay. You can still listen to the recording and get caught up with us. But we have one more prep session on April 29th, and this will be the most overview, logistics-oriented, what to expect for those 3 days, how will you participate in this virtual environment. We'll be covering all of those kinds of details, a little more visibility into who's testing, which steps. FHIR endpoints will begin to be available. We'll have documentation of all the participants and what roles they'll be playing. We do have 3 system roles in use case 1. The main actor is, of course, a system that's responsible for recording a clinical visit with a patient that we call the PMEHR. And that system is responsible for initiating some screening. Another system acts as a technical, or described as a technical actor that's responsible for doing screening, initiating that task, making sure that patients get screened, handling the interaction with a patient, and then returning that screening information back to the PMEHR. And finally, a third actor that's an actor that takes place at the very end after a clinical visit. There is an actor that can request visit information to be shared and then receive that clinical visit with the SDOH information included. So those 3 technical actors are the anchoring points of our interoperability testing. Then we have 2 human actors depicted. One will be the patient. we thought that would be an interesting thing to do. So interacting with the patient app to respond to screening, and even potentially to interact with that third actor. You could think of that clinical data registry repository was how we originally envisioned it, but you could think of it as a clinical data requester and receiver. And you know, as patients have the right to access their own health record information, we think it also would be relevant to demonstrate the patient requesting their clinical visit information and seeing how their social determinant of health information comes back in conjunction with their clinical visit documentation. So that's the patient role. A little bit on either side in scene 1 and scene 3 there of the use case. And finally, for folks that want to participate as a human role, not bringing a system, but want to help us document the activities that are the testing that's going on during Connectathon, do a little bit of going from scene to scene, watch how different systems are engaged in the information exchange, and help us document that so that we'll have a nice, rich history of what got tested and some of the screen captures and things that demonstrate the progress that we're making. That is the role of a documentarian, and we also are inviting people who want to participate in that role. There is a new care coordination track that you'll find off from that same area where you find the gravity track. And this track is an overarching track that focuses on how care planning and care coordination is taking place. It looks at many activities, many groups who are working on things besides gravity, but like ELTSS is a long-term support and services focus that looks at care planning. My head is just going blank on the other ones. PASIO, that's looking at functional status and cognitive status. And Evelyn, help me out. What's the third one?
Those are
the main ones, yeah. Right? Because the chronic, there is sort of a multiple chronic conditions kind of that's coming. It's not as far along, but that is a kind of a fourth focus that we're trying to bring all together. As we look at stitching together, I call this a quilt. We're really using that idea of demonstrating a play that kind of works in scenes and has different steps to it, and we're enlarging the span of what we're trying to bring together so that we can use the different tests that are going on in these 3 different areas and then demonstrate how they would all come together to accomplish a much larger use case than any one FHIR IG might be taking on today. And we're hoping that this will help these different groups that are working in a similar space to align better, to expose areas where there are maybe gaps or overlaps or things that are just not, the pieces aren't fitting together, or perhaps the pieces are fitting together and we just need to be able to see the larger flow. Next slide. Somebody needs to be on mute in the background who isn't on mute right now. Our focus in gravity on the 3 use cases is going to be incremental over time. So I just wanted to make sure that folks are clear when we go to Connectathon this coming May, it's going to be focused on use case 1. And this is a big bite to take already, so don't feel like it's going to be too easy. There's really plenty to do. Our FHIR implementation guide it's okay, you can move on to the next slide. Our FHIR implementation guide, where we are on version 0.0.3 right now, it still is just focused on use case 1. We have been starting our work on developing use case 2, and I'll talk to you a little bit more about that in just a minute. But in order to contain the technical aspects of developing the FHIR IG and all of the intricacies of the errors, the profiles, the value sets, the different parts that come together, we've taken an approach of putting our early work for use case 2 in a separate Trifolia artifact, which we will then be merging in together in what becomes version 0.0.5. So when you see 0.0.4 come out at the end of April, this is the version of the IG that we really wanted to have in its best possible shape to drive the Connectathon activity, both with HL7 and MyHIN. But it's going to still be largely focused on use case 1, and we will be doing that early work on use case 2 over in this other artifact and materializing that and then put them back together again before we go to ballot. So I just wanted to explain that to folks. If you're just wondering where use case is, it's making progress. We're still in the early phases of working on that. Next slide. Our content requirement work around use case 2 has been our primary focus. We are utilizing information exchange mechanisms that were already developed in another FHIR IG that's called bidirectional service request, BSER. So we don't have to reinvent the wheel when it comes to how to exchange the service request information. There's already patterns around establishing a task to exchange service requests and to receive information about the service requests, if they're completed, what status they're in, and what activities have been performed as a result. The important thing is that we need to identify the content and the coded content that's relevant for our specific gravity use case. And in where we are right now, this is focused on food insecurity. So the group that's been working on this has a pretty detailed spreadsheet that we've been building as we have enumerated the different individual data elements that would likely need to be shared. The purpose of this spreadsheet is to identify not only the concepts that are there, but where in a FHIR resource would you represent that information. So this slide summarizes for you the way that we've categorized a bunch of these data elements. And the next meeting, April 30th, I will introduce the whole spreadsheet to you, and that's what we will be using to get feedback. I considered trying to do it in some sort of a survey monkey survey, but it really, the spreadsheet itself has enough rows and intricacies to it that I couldn't envision doing that productively with a survey. So we're going to cap our work on the spreadsheet for April 30th and share what we have at that point with you so that the community will be able to give us feedback on the individual rows that fall into these categories. The categories are consent information, and we are doing quite a lot of envisioning, especially with guidance from our own technical advisory committee, around the importance when you get into social determinant type information of having patient consent to be able to share that. And it's not always governed under HIPAA when you're out in this area, so it's not like what we have when the information exchanges that are happening between covered entities. It's really a different space. So we've put some thought, work, and focus on consent information. There is, of course, patient information, and this is everything from name, date of birth, gender, address, phone number, language communication, all of the kinds of things that are relevant to and captured with a patient. There is referral information about that, the intervention that was the first one on the list that Sarah just reviewed for you. Who is making the referral, who is receiving the referral, and what type of services are being requested. There's additional things around dates and other detailed pieces there, but I just wanted to give you a sense of what referral information was. And then there's information that may accompany both the request and for the referral and also get updated when the feedback comes. I just listed it as supporting information, but supporting information is information that could both be shared upon requesting the referral or could be updated upon receiving feedback back from the organization doing the referral. So I listed, there's a few different kinds of things. It's kind of an interesting area in there, some things that we're considering that could potentially be shared, of course, with consent from the patient. could be around a history of prior program enrollments that could be known about by the clinician. It could be, again, optionally and with consent, perhaps some financial background information if the patient has already gone through a lengthy process like with a federally qualified health center where they're receiving a reduced rate for their out-of-pocket visit charges, things like that. There could be potential information available in the clinical environment that might be relevant or helpful when doing certain kinds of referrals. So that's all in the category of other kinds of supporting information. And then there's the information that's gathered during that clinical visit. Screening information, clinical assessment, other kinds of care planning around goals and planned interventions. Feedback information is the information on that closed loop, that 360X kind of closed loop. We would want to, or we envision being able to receive back information on whether the patient was enrolled, what programs they were enrolled for, information about that, what the enrollment status is, other potential care planning information, maybe updates on goals or updates on interventions or procedures that have been performed, and, of course, services that have actually been provided. So this is just a quick introduction to the kind of information that you'll see in the spreadsheet. I'm going to, we have time, I'm going to just take a quick look over here. I noticed a few questions coming in. I think this might be a good time. Aaron asks, for the track, I understand deferring to the EMR as a starting point for the interactions, but from an SDO perspective, I'd like to imagine that the role of the SDOH questionnaire order isn't limited to a clinical professional. Am I thinking about this wrong? I think no, Aaron. These transactions, the use case that we started with for Gravity was to imagine this in the context of a clinical care setting, but the individual transactions and the steps, the workflow doesn't necessarily have to start where we've started the story. So I think that when you dig into the FHIR IG and you look at the potential to return the screening information, you could envision it as an unsolicited sharing of screening information. Lynette, do you hear?
Yeah, we do.
I'm trying to figure out where it's coming from.
Okay, thank you.
I think it might be Aaron's side because we had this issue for the executive committee. Yeah, Aaron, I don't know if we need to dial off or something with his login. Sorry, Aaron. Thank you.
All right, great. And Lucy Johns was asking about 360X includes declined as feedback info. Is this pertinent here? Yes, thanks for asking, Lucy. There's a fairly complex state workflow that has been established by 360X. They really did a good job of looking at all of the different potential patterns, whether the referral is accepted or rejected. If the referral is accepted, but then for some reason either the patient doesn't want to have information shared back with the clinical environment or there's some other reason why it should not be shared back, there are many different state transitions that are possible that that the BSER FHIR IG aligned with 360X. So they went through a process together of making sure that the different state changes that 360X had identified could also be handled with the referral task that's described in BSER. And we feel that that's one of the important aspects of reusing the BSER work is that it does naturally align a large portion of the healthcare community because it's now making sure that we would be doing referrals in a similar way, whether the underlying transport mechanism is the use of direct or if the underlying transport is happening through FHIR-based mechanisms. Thank you, Lucy. Next slide. Stay tuned. More on that to come on the 30th. You'll get to see that. We talked about the different Connectathon roles already, system participants as well as humans. So I encourage everybody, because of this being virtual, it's very inexpensive to participate. You can sign up and let us know your interest at the Gravity Connectathon participation sign-up place. But that just lets us know that you're interested so that we can reach out and help you get started. If you want to secure a ticket to be able to actually dial in to the virtual Connectathon, you need to register through HL7. The second link on this slide is the actual HL7 registration. That's where you would put in your credit card, get signed up from a event point of view right there. And then finally, if you're considering coming to the Connectathon, we really encourage you to utilize the April 29th prep meeting as a way to get a preview of how this 3-day virtual event is going to run. This is materializing as we speak. There's a big group of people just thinking about how will we use our Zoom sessions, how will we use Zulip chat, how will we perhaps utilize our time so that folks will know what's going on in what places at different times. It's going to be like a 3-ring circus, a virtual 3-ring circus of activity, and so you definitely want to be prepared and know as much ahead of time about what to expect and how to participate. So definitely check out our prep session on April 29th. Next slide. That's it for me. Questions? Oh, I think there might be other questions. Let me see. Chris Bush, is there an aspect of this work that addresses differences in the type of encounter where the SDOH are collected, ER versus ICU versus office? I think our use case would be most similar. It's not as much addressing the ER or the ICU, although it certainly could fit. So if you take the role of the practice management EHR and any kind of clinical setting where it is determined that you want to initiate screening with the patient and then make sure that that screening information comes back and is attached into the electronic health record. That is the first scene within use case 1. So I don't think that we did anything specific to make our use case about, and our patient story is not really focused on the ER or the ICU, but none of the work that's documented in the IG would preclude these transactions from being used in those settings. Other questions?
Hey, Lisa, how do I get added to that Wednesday meeting list?
The Wednesday meeting list, yeah. So right now we don't send out. There's general reminders that go out to the whole Gravity community, pointing you to the sign up. But the best thing to do is to go find this page. And I don't have the ability to share my screen right now, do I? I don't want to transition the screen because we only have like 4 minutes left. So I will just say Natasha put the link in the chat. If you grab that right now before the meeting is over, that's your main page to get that sign-in, the login information for that call.
Awesome. Thank you so much.
Lisa, Deb is asking, will we accept screening from non-clinicians such as community health workers? And I can answer that. I think the standard does not specify there is an actor that conducts the screening. So we're agnostic on the type of provider that does it. So I think what we recognize, again, our patient story, as Lisa noted, the use cases themselves, the FHIR IG does not specify the setting. Our use case, though, is because our primary focus is documenting these elements within primary care. And so being able, our use case or our patient story talks through that. But we envision, and perhaps, again, this is another, we don't know enough right now. We developed it within the primary care practice as being the initial setting, but we know much of the screening is conducted in community-based settings. So as Lisa noted, the transaction is the ability to, request a screening that it could be done by a community-based provider administered in another setting, or our initial scenario is that the EHR sends a screener to the person's mobile app, and they respond, complete it, and send it back. The actor could be a community health provider that sends it back. Okay, I'm going to hand it, just in the interest of time, our next is our homework. So Sarah.
Hi, yes. So Lisa, thank you so much, and thanks to the community for the excellent questions. We did get one, how do you get a primer on FHIR question, and then that was in the chat as well. So for those of you who are new to FHIR, that was in the chat, and also our Confluence has a lot of information, and Lisa's been kind enough to give presentations previously in our work. So I want to direct those who are FHIR new to those resources. Major homework is submitting concepts via either the downloadable spreadsheet or the web tool. You can always find links on the Confluence. Any questions on that process, just send an email to the Gravity Project email. Again, I mentioned I'm going to top load a submission that covers some of the overcrowding concepts, and I'm going to try to jumpstart the goals conversation. So when we come back next week, hopefully we can have something to chew on. Next slide, please. Those are all introductory materials. Again, and this is actually in reference to what I was just saying. So there's introductory materials on the concepts in the coding systems and on data elements and how they're utilized. This is all available on the Confluence. Next slide, please. And then, so we're still doing the work on HMIS, HIT work. There's some pretty innovative stuff coming out of there regarding COVID-19 and rapid use cases. We'll talk about that, I think, next week or the week after. There's been a lot of conversation on data justice and data principles in the Technical Advisory Committee, and we hope to bring some of that work back to the public group in a couple calls once we reconvene next week. If you have any questions or thoughts, you can send me directly an email. Next slide, please. And then we already did this. Here we go, sign up for our 2020 Connectathon events. And then always, we welcome your official membership as a committed member. Again, on the Confluence is the process to sign up as one of those roles. And almost 5 on the hour. Look at us. Thanks again, team. It was wonderful to have your company on Thursday afternoon. We look forward to getting your data concepts and grateful for the work on FHIR that Lisa's doing. And if you have any questions, as always, just send an email. We're always here.
Thank you, everyone. We'll adjourn now.
Thank you.
Thank you.